Good afternoon, everyone. Before we proceed, allow me to pose this question to all of you. What would you do if you'd been in the shoes of an MDRTB patient? Multi-drug resistant tuberculosis, or MDR-TB, has become a global threat concerning to a risk of high mortality with the potential to cause adverse drug reactions, which, if not managed properly, may affect patient compliance, resulting in below-par treatment outcome. Treatment of MDR-TB requires the use of second-line anti-TB drugs, which are given for a longer duration. This afternoon, we will evaluate the common adverse drug reactions encountered throughout treatment using PMDT guidelines, and in the end, assess causality, severity, and preventability of adverse reactions during treatment. Before starting treatment, the patient should be instructed in details about the potential adverse effects of our DRTB medications, its relevant early signs and symptoms, and if and when to notify us. As healthcare workers, we play the most important role in providing psychosocial support. We have to educate our patients about adverse effects and encourage them to continue treatment. It is extremely important that patients realize that an MDR-TB regimen may be their last opportunity for cure. If the MDR-TB regimen is not taken in full, the strain may develop resistance to some of the drugs in the regimen, making any future regimen to rely on less effective and more toxic drugs. So how are we going to go about this? By active monitoring for serious adverse events, or SAEs, and passive monitoring for adverse drug reactions. Patients should be asked about possible ADRs, with attention to identification of toxicities or other evidence of issues in tolerability of the anti-TB drugs, and any ADRs or SAE should be reported immediately. All adverse drug reactions merit investigation and early action to limit harm. So proper strategies about ADR management have to be planned to maintain treatment adherence. Now, several best practices includes: 1, knowledge or educational intervention and proper counseling before and during treatment could build awareness and belief of necessity and convince the patients about the benefit of treatment. Number 2, healthcare workers have responsibility to deliver information to patients, to family, and the caregiver with comprehensive understanding about the disease and treatment, including the ADR and how to handle ADR. Third, psychological and educational support could improve both health-related quality of life and medication adherence. Number 4, never add a single drug to a failing regimen. And treatment and management of a DRTB case in which drug intolerance may complicate care should be referred to a specialist. Now, the severity of ADR can be categorized in major, including fatal, life-threatening, and severe, and minor, consisting of mild and moderate types. Now, all SAEs and AEs of special interest shall be presented to the TB Medical Advisory Committee and must be reported to FDA or Pharmacovigilance Monitoring System, or PVIMS. Now, skin rash is one of the leading adverse reaction caused by our anti-TB drugs. First, you have to evaluate for signs of severe rash, including involvement of mucous membranes, angioedema, and skin necrosis. You may also ask the patient for any history of drug allergy. Or You check for other potential causes of allergic reactions, like concomitant use of any medications. Food must be scabies or other environmental allergens. So for our mild allergic reaction, you may continue treatment and provide ancillary meds. These ancillary meds may be your antihistamines or your prednisone in a low dose. For moderate to severe allergic reaction, you may stop all anti-TB drugs pending resolutions of the reaction and provide ancillary meds. Hospitalization for severe reaction is also indicated. Now, in case of anaphylaxis, manage the patient with standard emergency protocols. And once rash resolves, you may reintroduce your anti-TB drugs one at a time, starting with the least likely drug to cause the reaction at a small challenge dose. Or you may also stop permanently any drug identified to be the cause of a severe reaction, and this may be replaced by another anti-TB drug. Persistent nausea and vomiting is usually caused by PTO, PASER or para-aminosalicylic acid, your isoniazid, ethambutol, pyrazinamide, cycloserine, linezolid, imipenem or cilastatin, and bedaquiline or BDQ. So for mild, you may have 1 to 2 episodes of vomiting separated by 5 minutes within 24 hours. For moderate, you have 3 to 5 episodes, and for severe, if your vomiting is more than 6 episodes within the day. Now, these are the following interventions to be done simultaneously. 1, you may advise the patient to take a light meal before drug intake. Or you may adjust timing of TB drugs, TB drug dosing. For our SSOR and individualized treatment regimen containing the drug proteonamide, you may start proteonamide in 2 divided doses that will be given in the morning and evening. For the first 2 weeks of treatment, if total daily dose is more than 250 milligrams. Once tolerance has improved, you may change proteonamide dosing to once daily after 2 weeks. But if there is no improvement despite the above intervention, or if the patient has moderate to severe nausea and vomiting, you may provide ancillary drug like your metoclopramide and give this to the patient as 10 milligram per tablet, 1 tablet 30 minutes before intake of anti-TB drugs. If nausea and vomiting persist despite intake of metoclopramide, you give ondansetron 8 milligram tablet, that's 1 tablet 30 minutes before intake of anti-TB drug. This can be given alone or in conjunction with your metoclopramide. Now remember, ondansetron can prolong our QT interval, so caution should be taken when concomitantly administered with QT prolonging drugs like our bedaquiline, moxifloxacin, and clofazimine. So this is the algorithm in how to manage nausea and vomiting. For gastritis and abdominal pain, this may be an early symptom of severe disease effects such as pancreatitis, hepatitis, or lactic acidosis. So if any of this is suspected, you have to request for appropriate laboratory tests to confirm the diagnosis and suspend the offending drug. Or you may consider other possible causes of gastritis and abdominal pain. So the possible anti-TB drug that cause gastritis and abdominal pain may be your pasir, your proteonamide, your clofazimine, your fluoroquinolones, your isoniazid, your ethambutol, or your pyrazinamide. So you may stop any NSAID that the patient is taking if this is the cause of your gastritis or abdominal pain. Or you may also diagnose and treat H. pylori infection if that will be the offending agent. Now, several abdominal pain has been reported with the use of clofazimine. Although considered rare, if this occurs, clofazimine should be suspended. So for persistent diarrhea may be caused by your drug pasir, proteonamide, or your fluoroquinolones. So if your patient has loose bowel movement of less than 4 times a day, so that will be considered as mild. And if it is more than 4 to 6 episodes per day, that's moderate. And if it's more than 7, that's severe. So for moderate to severe diarrhea, if it's uncomplicated, meaning there's no fever and non-bloody stool, you can give our ancillary meds loperamide, 1 capsule every after each loose stool, to a maximum of 16 milligram per 24 hours. So joint pain is also common among our DRTB patient, and this is frequently observed in our patients. And your drug pyrazinamide, fluoroquinolones, proteonamide, and bedaquiline are known to be associated with joint pain in patients receiving our treatment. Now, for mild to life-threatening, you can check for any presence of acute swelling, redness, and warmth in a joint. Now, if present, you may consider aspiration for diagnosis or to rule out any possibility of gout, infections, or autoimmune disease. Now, for moderate to severe arthralgia, we can give NSAIDs like your mefenamic acid, indomethacin, and celecoxib to ease the pain. Remember, your uric acid levels may be elevated in patients taking pyrazinamide. So if gout is present, you initiate treatment and give allopurinol. So that is the algorithm for the management of joint pains. Now, what about headache? So if your patient is having moderate to severe headache, so you can initiate therapy by giving NSAIDs. But if it's only mild, you may encourage to increase oral fluid intake, and also you can maximize vitamin B6 or pyridoxine to 4 tablets a day, especially if your patient is taking cycloserine. So if your patient is manifesting these following signs and symptoms of nausea, vomiting, jaundice, icteric sclera, tea-colored urine, pale stool, or even diminished appetite in the setting of your elevated liver function test, so please entertain hepatitis. Or you may also investigate for other causes of hepatotoxicity. It could either be alcoholic and non-alcoholic liver disease, viral hepatitis, or concomitant medications aside from our drug TB. So for mild elevation of liver enzymes, that's 1.1 to less than 2 times the upper limit normal. So this may be related to the disease rather than the adverse effect of our treatment. Generally, hepatitis due to medication resolves upon discontinuation of suspected drug. For our HIV with MDRTB co-infection, the drug nevirapine and cotrimoxazole can be a cause of hepatotoxicity. So a repeat laboratory and diagnostic test, like your serologic test for hepatitis A, B, or C, can be requested, or you may also request for a hepatobiliary ultrasound. So if your liver function test is more than 8 times the upper limit normal, so that could be considered already as a life-threatening. So remember the drugs pyrazinamide, isoniazid, ethambutol, your proteonamide, your para-aminosalicylic acid, your BDQ, clofazimine, and linezolid may be the possible anti-TB drug that will cause hepatitis. So how are we going to reintroduce our anti-TB drugs? So you introduce anti-TB drugs once liver enzymes return to baseline. Anti-TB drugs should be reintroduced in serial fashion by adding a new medicine every 3 to 4 days. The least hepatotoxic drug should be added first, while monitoring liver function tests after each new exposure. Now, you can also consider suspending the most likely offending drug permanently if it is not essential to the regimen. This is often the case for pyrazinamide if it is less likely to be effective by clinical history. And you may consider additional anti-TB drugs to reinforce the regimen. Next. Peripheral neuropathy is a common side effect of MDR-TB treatment caused by drug toxicity to the nerves of the peripheral nervous system. So signs and symptoms include numbness, tingling or burning sensation, or even pain in the feet or hands. So if our patient complain of the following signs and symptoms, so we have to grade them by using our BPNS scoring or brief neuropathy screening. So step 1, you have to elicit subjective symptoms using asking the patient to rate the severity of each symptom on the right and the left lower limb. So you may ask if the patient is having pain or aching or burning in his right foot or left foot or right leg or left leg. And then you do the scoring. Step 2, you have to grade the subjective symptoms. So grading, if it's between 1 to 3, so that's grade 1. If it's 4 to 6, that's grade 2. And if it's 7 to 10, that's grade 3. So if you have a BPNS score of 7 to 10, so that will be considered as grade 3 severe. So what are you gonna do is to give a narcotic analgesia to improve symptoms. Or you may investigate for other causes of peripheral neuropathy, such as maybe your patient has comorbidities like patient is diabetic, or your patient must be alcoholic, or there's vitamin deficiency, or patient is PLHIV, or patient has hypothyroidism, or patient may be taking another medications. So you have to manage accordingly. And you can also request for a specific laboratory and diagnostic test to rule out other cause of peripheral neuropathy. Many patients experience improvement when offending drugs are suspended, especially if the symptoms are mild. So if linezolid should be immediately stopped and no reintroduced when symptomatic neuropathy develops. So that's in grade 2 or above. So you may consider additional anti-TB drugs to reinforce the regimen. Now, all our drug-resistant TB patients taking linezolid should receive at least 50 milligram of vitamin B6 daily. Now, this is largely to prevent myelosuppression, but may also prevent peripheral neuropathy. For symptomatic relief, NSAID may help alleviate symptoms, or your tricyclic antidepressant have also been used successfully, like your amitriptyline, your carbamazepine, and your gabapentin. Now, take note, patients taking isoniazid, cycloserine, and linezolid should receive prophylactic pyridoxine. Now, what about the QTC prolongation? The QT interval must always be corrected for heart rate. The QT interval in an ECG is measured from the start of the Q wave, the start of the Q wave, to the end of the T wave. So that is how you're going to measure the QT interval. So the normal QTC in males is less than 450, while for females is less than 470. So the preferred way to calculate the QTC is by using the formula Friedrichsen method, which is derived by dividing the QT interval by the cube root of the interval in seconds between the peak of two successive R waves. So if you arrive at this computation, if you have a QTC of 450 to 480, so that is considered as mild. If your QTC computation is more than 501 millisecond or more than 60 ms change from baseline on at least two separate ECG, so that is considered as grade 4 and it is life-threatening. So the possible drugs that may cause prolongation of QT are fluoroquinolones, clofazimine, bedaquiline, and yordelamine. Now, you can investigate for other causes of QTC prolongation, such as concomitant medications, hypothyroidism, electrolyte imbalance, hypoglycemia, cardiac diseases such as history of syncopal episodes, arrhythmia, or severe coronary artery disease. So by doing so, you may request for other laboratory and diagnostic tests to confirm your diagnosis. Example, you can request for your thyroid stimulating hormones for entertaining hypothyroidism, or you may request for electrolytes like your sodium and potassium to rule out other possibilities of causing QT prolongation. Now, myelosuppression, is this common? Now, if the patient has thrombocytopenia, meaning your platelets are decreased, or neutropenia, so this is more likely to be due to our drug linezolid. So if your patient is having thrombocytopenia or neutropenia, you may increase your pyridoxine or vitamin B6 to a maximum of 200 milligram a day. So as you can see in the table, if the patient has 6.5 to 7.9 hemoglobin, so that can be considered already as grade 3 severe. So if you have platelets of less than 20,000, that is considered already as life-threatening. So you have to monitor regularly the CBC or complete blood count of your patient and look for any signs or signs of thrombocytopenia or neutropenia. And then you can also measure or compute for your absolute neutrophil count low. So again, you may also investigate for other causes of myelosuppression, such as nutritional deficiencies of the patient, any viral infections, or your patient may be having occult blood loss, or your patient is having HIV or AIDS, or you have chronic renal insufficiency, or maybe your patient is taking another medications aside from our anti-TB drugs. So for mild, you can decrease linezolid to half, that's 300 milligram daily. And then just monitor CBC weekly until the normal levels are reached. If you have moderate to life-threatening myelosuppression, you may consider giving blood transfusion. So for grade 4, in this case, blood transfusion should be considered. The whole blood count should be repeated weekly to assess the response to treatment. And please monitor also the blood pressure of your patient before initiation and monitor during therapy. Now, erythropoietin treatment should be in any case be discontinued if your hemoglobin reach over 12 grams per deciliter. So that's the algorithm for the management of myelosuppression. Now, depression. Is this common among our drug-resistant TB patients? So you can identify if there is any by simply asking 5 questions. Number 1, you may ask your patient if there's any mood changes, meaning if your patient is easily irritated, agitated, or he or she may be challenged to concentration. Or you can also ask if there's any change in sleeping pattern, if your patient might be insomnia or oversleep. Or you may also ask if your patient has any feeling of sadness, any feeling of hopelessness, or any thought to hurt herself or himself. So meaning if there's suicidal ideation. So if there's suicidal ideation, you may suspend cycloserine immediately and then refer it to a psychiatrist or maybe hospitalized patient, and you place under 24 hours safety surveillance. So this is a patient health questionnaire 9 or PHQ-9, and we are using this to assess patient with regards to the severity or grading if there's any of the depression. So if your PHQ-9 score is between 10 to 14, so that can be considered a moderate severity of depression. So the proposed treatment action for a moderate depression is to consider counseling and do the follow-up, or you may refer it to a specialist or psychiatrist, and a sertraline, which is our ancillary drug, can be given at 50 milligram per tablet. So again, as what I've mentioned earlier, if with suicidal ideation, you may suspend cycloserine immediately. So this is the PHQ-9 form. So from there's the criteria from 1 to 10, and then you do the grading. And then whatever your score is, so the grading can be from 0 to 3. So this is the severity grading scale. Now, psychosis is somewhat similar to depression because of our drugs. So the possible anti-TB drug will be your cycloserine, isoniazid, fluoroquinolones, prothionamide. So if you have moderate to life-threatening psychosis, so immediately stop the offending agent or drug like your cycloserine and isoniazid. Then refer to a specialist for evaluation and may initiate antipsychotic therapy. So the ancillary drugs available in our clinic are haloperidol and quetiapine fumarate. Now, what about seizure? Is this common? So if your patient is having seizure, so you have to, again, is number one is to grade and know the severity. So if it's mild, if it has brief partial seizure with no loss of consciousness. Now, if there's multiple seizure despite your medical intervention, so that can be considered grade 3 severe. So again, the same with our other adverse drug reaction, we evaluate for other potential causes of seizure. So you may ask or request as baseline for your serum sodium, potassium, or calcium, and magnesium. So for any seizure, hold your possible anti-TB drugs like your cycloserine, isoniazid, and fluoroquinolones. And then we can increase vitamin B6 or pyridoxine to a maximum of 4 tablets a day. And then, of course, you can always refer it to a specialist for further evaluation and management. And when the seizure has resolved, you can reintroduce our other drugs one at a time. Optic neuritis. So what is optic neuritis? This is an inflammation of the optic nerve, eventually resulting in permanent vision loss. The first sign of optic neuritis is usually the loss of green color distinction. This is best tested using the Ishihara test, and other symptoms include central scotoma. So what are the possible anti-TB drugs that will cause optic neuritis? You have the ethambutol, prothionamide, linezolid, clofazimine, isoniazid, and your streptomycin. Although we are not anymore using streptomycin because it's an injectable, and now we are using all oral drugs. So linezolid is by far the most common cause of optic neuritis among all of the TB drugs. So mostly after 4 months of treatment. So if you have patients with limited vision on the affected eye, like 20/40 on Snellen's, so that can be considered as moderate. If it's already there's blindness, 20/200 or worse in the affected area, so that's life-threatening. So you may, even with mild, moderate, and especially severe and life-threatening, please refer it to an ophthalmologist for consultation and further management. And in PMDT, we do monitoring regularly, and in fact monthly, especially if we still have the following meds using Snellen's and Ishihara. So for our patients with comorbidities like diabetes, they are at increased risk for optic neuritis, and they should be managed with tight glucose control as a means of prevention. Also, patients with advanced kidney disease are at increased risk for optic neuritis. What about hypothyroidism? So the possible anti-TB drugs that will cause hypothyroidism can be your proteonamide and the para-aminosalicylic acid. So if you have moderate to life-threatening grade, you can give levothyroxine. So for young healthy adults, you can start at 75 to 100 microgram daily. For older patients, so lesser dose at 50 microgram daily. And if we have MDRTB patients with significant cardiovascular disease, you may start levothyroxine at 25 microgram daily. And we also have patients, our children from 4 to 15 years, you can give levothyroxine at 4 microgram per kilogram per day. The maximum is 200 microgram. So far, we don't have infant patients having MDR-TB as of the moment. So for mild, those who are asymptomatic, so intervention not needed, you just have to monitor TSH monthly. Lactic acidosis is not common, but our possible anti-TB drug that causes lactic acidosis is your linezolid. So from mild to life-threatening, we always have to check for serum electrolytes, creatinine level, so as to know the renal function. If the need arises, you may also request for ABG, so you may know the lactic levels in patients with possible lactic acidosis. So you may entertain your patient having this adverse drug reaction if your patient is complaining of persistent nausea, vomiting, abdominal pain, lethargy. So you may stop linezolid and provide supportive care. So other rare adverse drug reactions includes tendon rupture. This is secondary to our drugs, fluoroquinolones, like your levofloxacin and moxifloxacin. So when you entertain tendon rupture, you may initiate treatment with NSAIDs. And you may advise your patient to avoid physical activities, and he or she has to rest the joints. Pancreatitis is also possible, although not common, and this is associated with the use of our anti-TB drug linezolid, isoniazid, and bedaquiline. And other possible adverse drug reactions to our drug proteonamide include alopecia, gynecomastia, and dysgeusia or metallic taste. So when this happens, you may encourage the patient to tolerate these side effects. And because resolution of these adverse effects may occur after treatment is stopped. So if we have to give interventions on the following adverse drug reactions, we have also modifications in terms of the severity of the adverse drug reaction due to our drugs. So how are we going to modify our regimen? So modifications of a treatment regimen can be done due to intolerance or toxicity that may lead to the negative consequences to patients, such as permanent disability, life-threatening, or it may lead to death or loss to follow-up. So just remember this. If modification requires replacement or premature discontinuation of more than 2 drugs, or complete discontinuation of our SSOR, shift it to individualized treatment regimen and refer this case to the TB Medical Advisory Committee for the approval. So these are the recommended replacement of our anti-TB drug in case your patient is having toxicity or intolerance to the drug. So for BDQ, so there's no recommendation to replace, but you may consult it with RTB map if there's a need to shift from one regimen to another regimen. Also, levofloxacin not recommended to replace. For clofazimine, if there's toxicity to this drug, so cycloserine is the first option. So if cycloserine is not available, linezolid is the second option. And this has to be given on the entire duration treatment. So if there's toxicity to prothionamide, example, persistent nausea and vomiting despite the intervention given and drug challenge and rechallenge done with PTO, so you may change it or replace it with cycloserine as first option, then linezolid as second best. So just quickly shift prothionamide to cycloserine or linezolid. And then for your pyrazinamide, ethambutol, and high-dose isoniazid, no need to replace. So as I've mentioned earlier, we can modify our regimen if severe intolerance or toxicity is experienced by our patient. So delamanid is the first choice to replace BDQ, Levox, or linezolid. Cycloserine, if never used before, may be used to replace clofazimine. And Passer, prothionamide, and ethionamide are the last option to choose for replacement. So this is true for our SLOR FQS regimen. So other alternative, if cycloserine cannot be used, you have prothionamide or para-aminosalicylic acid. And if ethambutol or pyrazinamide may be considered to replace clofazimine or cycloserine if your drug susceptibility testing confirms susceptible to either ethambutol or pyrazinamide. And if the oral anti-TB drugs cannot be used due to previous use in a failing regimen, so confirmed resistance or intolerance, you consider our group 3 drugs, imipenem, cilastatin, or our injectable amikacin or streptomycin if it's susceptible to amikacin or streptomycin by your drug susceptibility testing. So that ends my presentation. So as a parting words, burden of adverse drug reaction makes drug-resistant TB treatment to be a miserable period for patients. Adverse drug reactions generally tend to degrade quality of life of patients and potentially influence the adherence. A comprehensive support from family, community, and healthcare provider is required to help patients in coping with the burden of adverse drug reaction. Hence, routinely monitoring the predictability of ADRs with relevant clinical parameters and close watch on patient complaints can seize the issue and help improving patients' compliance, which enables them to tolerate adverse effects, resulting in a drop of the default rate. Okay, thank you very much for listening and have a pleasant afternoon.